Next speaker is Dr. Bhaskar SRINIVASAN, Senior Consultant in the Department of Cornea from Shankar Netralaya, with his teaching pearl on peripheral ectatic disorders, Tedious marginal degeneration and PMD. On to you, Doctor.
A very good evening to one and all, and I'll go through my talk quickly. Is my screen
Yes.
sharing? Yeah.
Yes.
So basically, when you're talking about ectatic disorders, especially peripheral ectatic disorders, you basically have corneal thinning, which involves the peripheral cornea. Sometimes you can have associated scleral involvement also. And when you look at what are the differential diagnoses that you would have, it could either be because of degenerative condition or it could be because of an inflammatory cause. The degenerative conditions would be a PMD, TMD, keratoglobus, or what we sometimes nowadays call as pellucid-like keratoconus, and the marginal furrow degeneration. And the inflammatory causes have already been covered today in terms of the Murren's ulcers, the PUKs. The other would be a microbial keratitis, which is involving the periphery, or something which is just which comes more like a pterygium, which is called as a Fuchs superficial marginal keratitis. So I would be concentrating on PMD and TMD in this talk. So coming to PMD, it's defined as a non-inflammatory progressive ectatic disorder, which is characterized by a narrow corneal thinning, which is separated from the limbus by about 1 to 2 millimeters. It's most commonly seen inferiorly, even though you have cases where you can see a superior PMD. Mostly it is bilateral, but it could be asymmetric. The important thing is the epithelium is intact. So if you're going to stain the eye, you will not see the fluorescein being taken up. The cornea is clear, and that is why the name comes pellucid, which basically means clear. And there is absence of scar, lipid, and vascularization, which is common as far as PMD is concerned. So these are very, very characteristic descriptions as far as PMD is concerned. And the photo here shows you the gross slit lamp view. And what are the causes? Basically, it is supposed to be idiopathic, but there have been studies where they have looked at associating it with keratoconus, even though it has not been proven. There is a slight male preponderance, but it's not again completely proven. It generally affects the older age group as compared to keratoconus, which affects the younger age group. The pathophysiology, like in keratoconus, it also shows breaks in the Bowman's membrane. There is thinning of corneal stroma. There is increased stromal mucopolysaccharide deposition. And if you look at the collagen in the ultrastructural base, you look at the periodicity of the collagen is actually increased to about 100 to 110 nanometers as compared to the normal 60 to 65 in the normal areas of the cornea, indicating the weakness of that area, and that is why it thins. And the appearance, because the ectasia and the thinning do not coincide, gives one an appearance of a beer belly as such. So when you're looking at PMD, one of the most common differential diagnoses would be how would you differentiate it from keratoconus, because that's commonly seen in clinical practice. So obviously PMD generally occurs at an older age group, and you can actually see it progressing also. I mean, keratoconus, we normally say after 35, 40 years of age, most patients do not progress, even though you can have occasional cases where there is progression. The vision compromisation in PMD is a little bit later as compared to keratoconus, where it happens earlier. You generally don't see the classical signs that you would see in keratoconus in terms of the Fleischer's ring, the Vogt's triad, scarring, and residue signs, even though you can occasionally have a hydrops and that can result in a scarring. The most important clinical thing here would be the fact that your thinning and ectasia do not coincide. So if you look at a PMD, you have a thinning, say it's inferior, and your ectasia is above that. Whereas if you have a keratoconus, you will normally have the thinning and the ectasia coinciding. If you look at the pachymetry maps, obviously the central pachy is a little bit more thicker in PMD, pure PMD cases as compared to keratoconus. The asphericity is less prolate in PMD as compared to keratoconus, where it is going to be hyperprolate. And the relative pachymetry mapped in terms of how fast or how rapidly the pachy reduces is also different. Again, it is important to look at the Scheimpflug image, because that gives you a picture similar to what you would see in slit lamp, and it clearly demonstrates the fact that your ectasia and thinning do not coincide. So just looking through a pentacam map, where you can see what is called as the classical bird beak or the crab claw or the kissing dove sign. And this has been said to be sacrosanct with PMD, even though now we know that just looking at this one picture, you cannot label it as PMD. You need to look at the elevation, but more importantly, you need to look at this pachymetry map. And the pachymetry map generally shows a peripheral crescent of thinning, or you can have something like a bell-shaped curve. Again, this is not an ideal map because it is only till 8 mm, and we take normal maps only till 8 mm. So when you're looking at a peripheral pathology, you need to look at the maximum cornea extent. So you would need to take the 10 or the 12 mm scans of the cornea. If you're looking at the K values, you will actually see a flatter area at 90 and a steeper in the 0-180, and this is what gives you the against the rule astigmatism. And if you're looking at the Q value here, it's still on the plus side, whereas a normal keratoconus would actually see it as a minus. And if you look at the 12 mm scan or the complete cornea scan, you actually see the thinning, which is much more prominent in this as compared to the previous map. Yes, there are a lot of data points which are extrapolated, but it still gives you a better idea about what you're dealing with. Again, don't look just at the thinnest point in your pentacam here, because this 423, even in the map, you can see it is much thinner. And if you actually go back and look at the Scheimpflug image, you will see it is even more thinner. This is important to note this thinning, because if you are going to be planning a cross linkage, you need to be sure that you have adequate cornea to safely cross link that eye. Again, coming to this particular pattern. So if somebody sees this kind of a kissing dove pattern, you cannot label it only as PMD, because like in this case, you look at the elevation maps, the elevation and the Pachy maps are coinciding. So your thinnest Pachy is coinciding with your anterior and anterior as well as posterior elevation, making it a sagging cone, or what we would call as a pellucid-like keratoconus. Again, you can sometimes have combined ectasia. So you can have this patient had a combined keratoconus with the eye drops, and he also had a PMD. The other eye only had a PMD, which was documented inferiorly. And you can sometimes have it combined with keratoglobus also. So when you're talking of treatment options, you have non-surgical options and surgical options. So non-surgical options would be with spectacles, soft toric lenses. These would be till the astigmatism is minimal. Once the astigmatism increases, you will have to shift to the RGP lenses, the hybrid lenses, or finally to these scleral lenses if you're looking at non-surgical options. Surgical options, if there is progression, you would, and if the thickness permits, you would consider cross linkage. You would want to decenter the beam so that you're focusing on the thinnest area. You are a little bit concerned that the limbus in that area might get affected. So these are things that you will need to discuss with the patient. If it's worse, you might need to consider a DALC or a PK. Other options are something like a crescentic wedge excision, which could either be a lamellar wedge excision or a complete wedge excision. You could do the tuck-in lamellar keratoplasty, as has been popularized by the AIMS group. You also have the option of using intracorneal ring segments, specifically, most likely a single segment, to improve the astigmatism.
1 minute remaining.
Yeah. And coming to the toric IOL in case of visual, good visual recovery. If the astigmatism is not very great and the vision with glasses is good. So these are just examples of patient where we have done a DALC and a patient where we have done a lamellar wedge excision. And it shows with the lamellar wedge excision, the astigmatism has come down from 16 to 4 diopters. Coming to TMD, again, basically it's infrequent idiopathic, bilateral symmetrical progressive disease with an intact epithelium, and generally seen after 40 years of age. And again, the BCVA is generally reasonably good, but it can have lipid infiltration, neovascularization, scar, and it can rarely cause perforations. And this could also be resulting in a corneal cyst filtering bleps, resulting in hypotony. So etiology, again, you have a degenerative cause, you have an inflammatory cause, and you have the possibility of phagocytosis caused by the histiocytes. The confocal microscopy does show some amount of inflammatory basis, but these are not clinical. Again, the staging of the disease is important to know how you would want to manage it. And this staging is being given in a publication in survey, where they say a stage 1 is a gray white opacity in the superficial cornea, a stage 2 is with a furrow, a stage 3 is a locally ectatic cornea, a stage 4 is a totally ectatic cornea, and a stage 5 is a corneal scar. Again, this patient had severe TMD in one eye and an early TMD in the other eye. And if you look at the Scheimpflug image, it shows the same. And you can actually see the early ectasia in terms of bulge when you look at the OCT, and it does show a scarring secondary to the lipid deposition. This is a grade 3 TMD. Again, treatment options are non-surgical with respect to glasses or contact lenses, RGP or sclerals, and surgical would be with respect to LK or PK. And you have various options. You could either have as an annular graft, you could have a crescentic graft, you could have a full penetrating keratoplasty, or you could have various versions of lamellar keratoplasty. So this patient had a crescentic lamellar graft, followed which the patient underwent a cataract surgery. Post the lamellar graft, the astigmatism did improve, and we were able to go ahead with the cataract surgery, and she recovered fairly good vision. The other eye with an early TMD, she just underwent a regular cataract surgery and is doing fine. A patient with a more advanced disease ended up with requiring a large crescentic graft, and you can see in the OCT the both edges of your tissue when the scan has been taken at 0-180 degrees. This patient with a TMD ended up with a trauma resulting in a perforation. We had to do a scleral patch, corneal patch graft in that eye. And the other eye had an annular 360-degree thinning, and we did a prophylactic 360-degree annular LK. And this is how the Scheimpflug image was there, which shows the significant thinning on both the superior and the inferior aspect. And the pentacam image shows a significant steepening all around, with the central area still reasonably preserved. And that is why the vision of the patient was still good. And this is the pre-op, and this is the post-op after the annular graft was done, maintaining the central curvature reasonably well. So the vision is also protected, and we have stabilized the peripheral thinned area. So the risk of globe rupture is minimized. So to conclude, peripheral ectasias can be challenging. A good clinical evaluation and a tomographic evaluation is important to achieve, to arrive at an accurate diagnosis. And you might have to plan surgical options based on a case-to-case basis. There's no single answer to all your patients' problems. Thank you.
Wonderful talk, Dr. Bhaskar. Dr. Praveen, one question before we go on to our last speaker.
This is like a quota one question.
No, I have because I'm a cataract surgeon, I have a very simple question to ask. If you have a person with the cataract and this kind of a situation, would you do the corneal treatment first, or would you do the cataract and then follow it up with treating the cornea? Because this is, after all, an older age problem, like keratoconus. Patients whom you do cataract, you do know that the keratoconus part has become stable.
So for PMD, I would probably want to follow the patient up, be sure that it's progressing or not. If it is progressing, I would do a cross linkage and then plan for treatment. Because if it is not progressing, and you've seen the patient for maybe about a year or 2 years, and the glass vision is good, you might even consider putting in a toric IOL to the extent of at least reducing his dependence on glasses. Yes, quality of vision is not going to be as good as with contact lenses, but whatever he's able to get with glasses, he'll probably be able to get with a thinner pair of glasses. And again, if it allows you, you could consider doing a topography guided ablation along with the cross linkage to improve the curvature a little bit more, and then plan your cataract surgery subsequently.
Good. Yes, Dr. Praveen?
I just wanted to ask, considering the variability of the outcomes of surgery in such corneas, Bhaskar, great talk, by the way. Would you consider contact lenses, especially like large diameter scleral lenses, a major part of your treatment for these patients?
Yeah, primary the treatment is going to be contact lenses, because I mean, if you look at DALC, probably the astigmatism is less. All the other surgeries that we do, wedge excisions, annular, crescentic, everything ends up with astigmatism, because we are not able to get the exact curvature that we would want. So if surgery has to be decided, I would probably go more towards a large diameter DALC, but then the risk is if you end up with a perforation, you end up with a large diameter PK with its inherent risks. So I would probably push the patient more towards contact lenses and plan surgery only if that's not acceptable to the patient.
It's very unfortunate. I missed you, Dr. J.K. Reddy. I looked for you in the beginning, but I think you had other commitment. Would you want to add something at this point of time? You have to unmute yourself.
No, nothing.
Sorry, I missed you.
Yeah, this contact lenses that Praveen has said, the fitting contact lens also very difficult in advanced PMD, because the lower part is bulged away from the limbus. Even 26 millimeters contact lens, we tried advanced cases. It's almost they rub on the cornea, thinnest portion. We are finding very difficult to fit even scleral contact lenses in advanced PMD. Though it's given in the books, when you put the lens and see, they are very, very bad. They push the lens away and a lot of air comes up, and the gap is more than 2 millimeters in the center, and even specially designed. Unless we make a asymmetric, which are not possible in India, only Boston can make asymmetric posterior curved lenses. They can make.
Yeah, they are available in India. We make them for Boston Foundation.
Asymmetric down. Asymmetric down. We need a nanoform. Which is around 6.5 crores. That's the problem.
We have a nanoform.
Mm-hmm.
And we made those lenses. We'll send you a few if you want.
Yeah. This is good. Thank you.